The kidneys regulate fluid, acid, base, and electrolyte balance while eliminating waste from the body. With renal failure, it can be diagnosed as either acute or chronic. Acute renal failure can result in a chronic renal failure without aggressive treatment, or when complicating pre-existing conditions exist. With acute renal failure, there is a sudden cessation of renal function, and that occurs when blood flow to the kidneys is significantly compromised. It is the leading cause of death among hospital clients, and 50% is due to an iatrogenic cause, which means we did it. We caused it. Something we did caused the renal failure. That's not good. It has 4 phases. The onset begins with the onset of the event, and it lasts for hours or days. Second phase is oliguria, and that begins with the renal insult and lasts for 1 to 3 weeks. Diuresis begins when the kidneys start to recover, and that can last for about 2 to 6 weeks. And recovery continues until renal function is fully restored, and that can take up to a year. Pre-renal failure from volume depletion or prolonged reduction of blood pressure is the most common cause of acute renal deterioration, and it's usually reversible with prompt intervention. If you look in your textbook, you can have a look at these 4 phases, because then when we go on to chronic, we can see that there's 5 different phases. Chronic renal failure is progressive, and it's irreversible kidney disease. End-stage renal failure exists when 90% of the functioning nephrons have been destroyed, and there's no longer any ability for it to maintain fluid, electrolyte, or acid-base homeostasis. Chronic renal failure, like I said, has 5 stages. Stage 1, there is minimal damage with normal glomerular filtration rate. Stage 2, mild kidney damage with mildly decreased GFR. Stage 3, moderate kidney damage with moderate decrease in GFR. 4, severe kidney damage with severe decrease in GFR. And 5 is kidney failure and end-stage renal disease with little or no glomerular filtration rate. Dialysis or kidney transplantation can maintain an individual's life, but neither one of them are cures for chronic renal failure. They may be asymptomatic except during periods of stress, which would be like infection, surgery, or trauma. And as renal failure progresses, chronic or clinical manifestations become much more apparent. So the actual signs and symptoms we see of individuals who have renal failure are, well, actually, I guess we should talk about risk factors first. Let's talk about the risk factors. So when we look at the risk factors for the acute patients, there is a certain culture or that cultures or races that are at more higher risk, or we see a higher incidence in, and that is Asians, Native Americans, and African Americans. That's for acute renal failure. And the risk factors for acute renal failure include pre-renal, intrarenal, and post-renal causes. So pre-renal, that occurs before damage to the kidney occurs. So we'll see that with hypovolemia that is resulted from hemorrhage, dehydration, burns, prolonged vomiting, or diarrhea. There is a decrease in cardiac output that results in reduced renal perfusion, and that can be because of a MI, cardiogenic shock, cardiac arrhythmias, heart failure, pericardial tamponade, or open heart surgery. There could also be a decrease in peripheral vascular resistance, and that could be from renal artery stenosis, septic shock, anaphylaxis, or neurological injury. Or we could see it happen from renal vascular obstruction, and that could be because of maybe there's a thrombus in the renal arteries or the veins, or an embolism. With intrarenal, That occurs within the kidney, so the damage is usually irreversible and probably is the cause of acute tubular necrosis. Nephrotoxic injury can be caused by certain antibiotics when we talk about them being nephrotoxic. It could be from overuse of NSAIDs, could be from organic solvents, it could be from the contrast dye that we talked about during procedures, heavy metals, and hemolytic transfusion reactions. It could also be caused from acute glomerular nephritis, acute pyelonephritis, toxemia during pregnancy, malignant hypertension, systemic lupus erythematosus, or interstitial nephritis. So those can all be intrarenal. Postrenal is an obstruction of strictures leaving the kidney, so on the other side of the kidney. Renal calculi, number one cause. Could be urinary tract obstruction, prostate cancer, bladder cancer, trauma, strictures, or spinal cord diseases. So that would be the acute renal failure risk factors. The risk factors for chronic include acute renal failure, diabetes, chronic glomerular nephritis, nephrotoxic medications such as gentamicin, NSAIDs, chemicals, hypertension, and it's especially prevalent among the African American population, autoimmune disorders such as lupus, polycystic kidney disease, pyelonephritis, renal artery stenosis, and recurrent severe infections. Our older adults are at an increased risk for renal failure related to the decreased number of functioning nephrons they have. They also have a decreased glomerular filtration rate, and water and sodium conserving and compensatory mechanisms are also diminished. There is an increased incidence of chronic renal failure is related to the prevalence of diabetes, hypertension, and the use of NSAIDs in the older adult population. So in general, the signs and symptoms that we see objectively, or let's start with subjectively. So subjectively, they will complain of fatigue, lethargy, maybe restless leg syndrome, a depression, intractable hiccups is also a subjective complaint. Objectively, it's related to fluid volume overload. Renally, we'd see polyuria, nocturia, that's early on, and then oliguria, and then anuria, which is late. Proteinuria, hematuria, and when the urine is present, it's a dilute color. Cardiovascularly, with the fluid volume overload, we're going to see hypertension, peripheral edema, pericardial effusion, congestive heart failure, cardiomyopathy, and orthostatic hypotension. The fluid volume overload in respiratory, we would see dyspnea, tachycardia, possibly uremic pneumonitis, crackles, Kussmaul's, and pulmonary edema. Hematologically, anemia, bruising, bleeding. Neurologically, lethargy, insomnia, confusion, encephalopathy, seizures, tremors, ataxia, paresthesias, and coma. GI, we'll see nausea, vomiting, anorexia. They may complain of a metallic taste, stomatitis, diarrhea, uremic halitosis, so they have a bad breath, and gastritis. With their skin, we will see a decreased skin turgor. They may have a yellow cast to their skin. It'll be dry, pruritus, and a late sign is that uremic frost on the skin. Musculoskeletal, osteomalacia, which we know is softening of the bone. We studied that earlier. And muscle weakness, pathologic fractures, and muscle cramps. And reproductively, there could be erectile dysfunction. Labs we're going to look at are urinalysis. We're looking for protein, hematuria, alterations in specific gravity, The serum creatinine, we're going to look a gradual increase of 1 to 2 milligrams per deciliter per day for 1 to 2 days with acute renal failure, and then a gradual increase over months to years with chronic renal failure, which exceeds 4 milligrams per deciliter. The blood urea nitrogen, the BUN, an increase in that gradual with chronic over months to years, and within a week it'll pop up with acute. Serum electrolytes, we'll see a decrease in sodium. It could be dilutional, and calcium. We'll see an increase in potassium, phosphorus, and magnesium. Our CBCs, we're going to see a decreased H&H from the anemia, which will be secondary to the loss of erythropoietin with our chronic patients. Diagnostically, we'll radiology procedures, ultrasound, KUB, CT, angiography, cystoscopy, all those things we talked about in our other talk. Well, let's look at what our nursing care includes. We're going to look at abnormal findings and report those, any urinary elimination pattern changes, the amount, color, odor, consistency, vital signs, if it's up or down, the blood pressure, their weight, daily weight increase of 1 kilogram, which is 2.2 pounds, is approximately 1 liter of fluid retention. We're going to assess and monitor vascular access or peritoneal insertion site, peritoneal dialysis insertion site. So we're going to look at their accesses. We're going to provide the client with a diet that is high in carbohydrates and moderate in fat. We're going to restrict their intake of fluids, and that's based on their urine output. Typically, we're going to only allow about 500 to 700 more than they output a day in. We're going to balance their activity and rest, prepare them for any dialysis, whether it's hemodialysis, peritoneal dialysis, or hemofiltration if they're in the hospital, and that will probably be covered next semester in critical care. We're going to provide skin care to the client to increase their comfort and to protect them from breakdown. We're going to protect them from injury, support them emotionally, encourage them to ask questions, discuss fears. If they're facing a lifelong dialysis ahead of them, it's huge impact on their family and themselves and perhaps their role. So there's a lot of psychosocial support that needs to be provided. We're going to encourage the client to diet, exercise, and take medications to control their hyperlipidemia if they have that, and give them meds as ordered. For clients who have acute failure, we're going to treat the underlying cause. We're going to prevent prolonged episodes of hypotension and hypovolemia because we know those will put it at greater risk for failure. We're going to prepare for fluid challenge and diuretics during the pre-renal period if azotemia, the pre-renal period of azotemia if the client is showing signs of fluid volume deficit. We'll do that. We're going to restrict fluid during the oliguric phase and restrict dietary intake of protein, sodium, potassium during that oliguric phase. And that restriction is for the client who is not getting dialysis. It's only for them if they are not on dialysis. We would restrict their protein, sodium, and potassium. For clients with chronic, we're going to get a detailed medication and herb history to determine their risk for continued renal insult. We're going to control their protein intake based on the stage of renal failure and type of dialysis they're on. We're going to restrict their sodium, potassium, phosphorus, and magnesium. And we're going to encourage the patient who has diabetes to adhere to strict monitoring of their blood glucose. because if they are uncontrolled, they are at major risk for renal failure. Medications, I'm going to do that on the next slide. Medications we see with renal failure include cardiac glycoside digoxin. This increases the contractility of the myocardium and promotes our cardiac output. Make sure that we are doing our apical pulse with these patients 1 minute for a whole minute prior to giving the medication, and we're going to notify the provider if the heart rate is less than 60. We're going to teach the patients to do that daily before they take their medication, and have them notify their doc if their pulse is less than 60. We're going to talk to them about digitoxicity and the signs and symptoms of digitoxicity. Sodium polystyrene, which is K-oxalate, to increase the elimination of potassium. They may need to go on this. We want to look at the potassium level, monitor vital signs. We're going to give really cautiously with patients who have comorbidity of heart failure, hypertension, or edema. And also, we're going to monitor patients who are taking dig cautiously with this. Erythropoietin alpha, which is epogen and procrit, and this stimulates the production of red blood cells, and it's given for the anemia. So we'll monitor our patients' H&H. We're going to look at their blood pressure, and it is contraindicated with patients who have uncontrolled hypertension. We'll use this medication also cautiously with patients who have bone cancer. Anyone who is on this, they will have to have blood drawn twice weekly to monitor their H&H. Iron supplements such as ferrous sulfate, that's to increase their iron level within their blood. And this medication is given after dialysis if they need it, and a stool softener needs to be given with them. As we know, iron will cause constipation, and we want them to take it with food. Aluminum hydroxide gel, which is Amphagel. It's a phosphate binder, and it's used to increase the elimination of phosphate. We want to use stool softeners with this because it causes constipation, and we don't want to use this with patients who have they have renal disease. If they have a GI disorder, we're not going to use it. And we want them to report any signs of constipation with the Amphagel. And then diuretics such as Lasix, but we do not use diuretics in end-stage renal disease. This is only with acute and chronic. Once it hits end stage, we're not using any diuretics. And that's to excrete excessive fluid. Of course, we're going to watch blood pressure, INOs, daily weights, and let us know if they're having any increased thirst, coughing, or lightheadedness. Patients who have acute and chronic renal failure will be seeing a nephrologist to manage the dialysis or the renal failure and/or renal failure. Nutritional service is really important with this population because of the changes that they have with their electrolytes, as well as their inability to manage the protein. So our patients teaching their daily intake of carbohydrates, protein, sodium, and potassium has to be done, and that's according to the provider who's going to prescribe it for them in individuals. Their fluids, INO, fluid restriction, they need to be taught about that. They need to avoid any antacids that have magnesium in them. They have to really watch their over-the-counter medications. Make sure that they have rest activities. We need to talk to them about their dialysis or peritoneal dialysis, how they're managing that, the importance of coming to these appointments, how to measure their blood pressure, their weight at home, how to check their dialysis ports, encourage diet, exercise, medication compliance, and to watch for skin breakdown. Complications that we can see: hyperkalemia. If we see that, mostly renal failure patients, they're going to have electrolyte imbalances. But if they have hyperkalemia, we're going to use Kayexalate or insulin as prescribed. If they have hypertension, they'll go on antihypertensives, probably diuretics. Seizures, we'll implement seizure precautions and use any antiepileptics that are prescribed. If they have dysrhythmias, we'll provide life support interventions, monitor and report non-lethal dysrhythmias. Patient goes into pulmonary edema. With renal failure, they'll probably put them on dialysis right away and get off that extra fluid. Infection, surgical asepsis for any invasive lines. That includes their peritoneal dialysis port as well as their vascular access ports. Metabolic acidosis is another complication. We can dialyze them to reverse that, and uremia. We could also dialyze them to attempt to reverse that.